Trigger points. The term trigger point was coined in 1942 by Dr. Janet Travell, and it was to describe a clinical finding with the following specifics: pain related to discrete, irritable points in skeletal muscle or fascia, not caused by acute local trauma, inflammation, degeneration, neoplasm, or infection. The painful point can be felt as a nodule or band in the muscle, and a twitch response can be elicited on stimulation of the trigger point. Palpation of the trigger point reproduces the patient's complaint of pain, and the pain radiates in a distribution typical of the specific muscle harboring the trigger point. The pain cannot be explained by findings on neurological examination. So what does that mean in simple terms, in terms of what we're looking for in our day-to-day massages? So sometimes when you've done all your effleurage, petrissage, you've tried some SDR, some MET, you find there are still some stubborn patches of tissue that's still tight, or bands of tissue that's still tight, or that isn't letting go. That's typically where you'll find trigger points. It's those last trigger points that are holding that band of tissue tight. So pressure onto those trigger points produce or reproduce the pain symptom. So again, very common symptom. Someone might say you might be working through the upper traps, which refer to the head, and you'll hit that tender spot in the band of tissue, and they'll say, oh, that goes right up into my head where I get the headache. Or they might say, oh, it goes down my arm. That's what happens when I feel that neck pain, etc., etc. So it's communicating with your client can also confirm that it's a trigger point. Pressure onto the TP can also create any radiating pain or symptoms. So again, it may not reproduce the client's symptoms that they came with, but when you get onto that trigger point and apply pressure, they'll say, oh, I feel that go down my back or down my arm, up my neck, etc. That's a feature of these trigger points. And the truth is, any muscle in the body can develop a trigger point. If it's overused, fatigued, over-dominant, being pulled long, lots and lots of reasons. They can be as a result of overuse, postural problems, strain, injury and healing, even due to psychological conditions, including stress, for example, where we often see those upper traps, SCM scalenes, become hypertonic, tight and tense. So there are lots of books out there for trigger pointing. And what I always say to people is not that they're not useful, but buy with caution. Some people will tell you, they will go straight in on a point in your leg and say, okay, I'm just trigger pointing the calf. This is where trigger point is for calves. But who's to say that's where the trigger point is for you in that calf, or that you even have a trigger point in that calf? And that's where I think we need to not take this literally. Yes, the trigger point could be in the muscle belly of the calf. What is very useful in those trigger pointing books are the referral patterns. Sometimes to be able to show a client an image of the referral point in the upper traps, for example, in the head, and say, does this picture, any of these pictures maybe represent where they get the pain in their tension type headache? That can be useful. Or sometimes you'll get weird and wonderful pain complaints where on certain actions people, for example, get pain between the bicep and the tricep. So in neither muscle, but almost between the two. That is a trigger point referral pattern for the supraspinatus. So it can be quite useful in that fact-finding detective work that we do. So what causes these trigger points? So we've talked about what might cause them in terms of overuse, etc., etc. So that's useful as to the why they're being found in a specific muscle, but why they behave as they do, why they respond to trigger point therapy, we don't really know. So again, take your pick. But our theory is that it's nervous system response, and that is what we're going to talk about here in terms of what we think is happening when we do trigger point therapy. So what the science says, although we don't know why it works, what we do know is that it does work. Trigger point therapy has been shown to reduce pain, to be really effective in tension type headaches, so to reduce both the pain level and the frequency of those types of tension headaches. It's been shown that it does reduce muscle tension and it can also contribute to improved joint function. So there are lots of reasons as to why we want to integrate trigger pointing into our hands-on work. Why it works, we still don't know. So I think we need to be careful not to make claims that I've heard we're separating fibers, we're breaking down nerves, all sorts of stuff. We can theorize as to what we think might be happening, but the truth is we don't know yet. So what is trigger point therapy? Well, trigger points actually dissipate on a lot of general massage techniques. Effleurage, STR, petrissage, even MET can get rid of trigger points in the tissue, and they're very pleasant ways of getting rid of those trigger points. If following general massage and the application of your other techniques, a tight band of tissue remains within the soft tissue you're working on, then trigger point pressure therapy can be applied. It's a neuromuscular technique where we place a static ischemic pressure onto that tender point until the pain disperses. Trigger points rarely travel alone. You may find that one trigger point is more painful or stubborn than the others. You might need to trigger point it twice. It might take a minute of pressure to go away, where there are others that surround it very closely, mere millimeters away from it, that dissipate almost immediately on touch after 10-20 seconds, and we tend to call those satellite trigger points. So what is our process? So following a general massage, we're going to find those bands of tension within the tissue that's not letting go. We're not going to assume there's trigger points there, so we need to communicate with our clients. Communication is at the center of trigger point therapy. If your client has to think about whether it's tender or not, it's probably not a trigger point. As we said, these are points of exquisite tenderness. When you hit one, your client will know. Hold the pressure at a constant rate. This is an important check. If the pain gets worse after 10 seconds, get out. That's an indication of actual tissue damage. So yes, it probably is very tender, but that's because it's torn tissue, for example. Refer to an injury specialist in those cases. But if the pain remains the same or starts to fade, it's likely it is a trigger point, so keep that pressure there. It can take 30 seconds to over a minute for the trigger point to fade. Always ask your client to let you know when the pain fades. So how much pressure? Originally it was taught and thought that the pressure had to be constant. It had to be ischemic static pressure. But that advice has changed, where we're being told to listen to the tissues more. The late Dr. Leon Chaito, who's a world-renowned therapist, recommends that if your pressure causes the muscle to tense up and push you out, then use less pressure. But as you feel the muscle relax and let go, you can add a little more. So as with anything we do, listen to the tissue, listen to your client, and respond accordingly. So if you're interested in finding out some more information, or here are some references to research papers that show the benefits of trigger pointing, check out these links.